do people from the Netherlands live abroad in New York? How do they live and work in the city that never sleeps? That's the question to which this Club NYC podcast will give you the answers.
Thank you, everybody, and welcome here at the NL Club vodcast. And after the last episodes where we were talking about business in New York, today we're going to talk about another important matter, and that is healthcare in New York. And you would not think of it, but it's one of the most important things you should think of when you either want to live, when you either want to work, or when you want to do something else in the US. And the thing is that we got 3 health experts here today to discuss this, to talk about it. And why don't I just start today with a little introduction, and let's start on my left side. Please tell me, who are you and what brought you to New York and what are you doing here?
Thanks. Well, my name is Marthe Haverkamp. I'm trained as an infectious disease physician in the Netherlands, and I worked in the academic medical center in Leiden. I got my PhD in immunogenetics from Leiden University. But at the same time also worked in healthcare policy for the Dutch government. I worked for the RVZ, and I think that's now called de Raad voor de Volksgezondheid, de Raad voor de Volksgezondheid en Zorg, zoiets.
Public health.
In ieder geval. Then I came to the US on several fellowships. The first one was a Fulbright in 2003, and I did part of my PhD at the National Institutes of Health in Bethesda, and that's where I met my husband. And 10 years later, got a Harkness Fellowship from the Commonwealth Fund, and that allowed me to do research for 2 years at the Harvard School of Public Health in Boston. We moved to New York, and for the last 5.5 years, I worked as a senior director at Alvarez & Marsal, and that's I worked in healthcare consultancy for big systems, health systems, and physician groups. And I became an American, and I have now 3 American kids in American high schools.
Wow, yeah. It's like the dream story of a lot of people from the Netherlands and just, being here. Thank you so much for coming.
Yes.
Who are we sitting next to you?
Well, my name is Jaap Boelens. I'm a pediatric oncologist. I work here in the city in a cancer center, Memorial Sloan Kettering Cancer Center. I'm the chief of the department for cell and gene therapy. And I moved to the US with my wife, who is also a physician, works in the same hospital, and with 3 girls. And 2 of them did high school here. They are actually back in university in the Netherlands. And we live with the youngest daughter, who is 12, so she is middle school. I did most of my training in Europe, and we moved 7 years ago, 6.5, 7 years ago. So I'm also working in healthcare, seeing patients, doing research, managing and service.
Amazing. And what are the ages of your daughters?
So my youngest one is 12. And the oldest one is 22, and the second one is 20.
Wow.
Yeah.
And they went back to the Netherlands.
Actually, the first one went back right after high school. She did IB high school here. The second one went to the West Coast after 4 years New York, but she didn't like it that much. So she decided to do semesters for UCLA in Delft. And she loved Delft, so she said, I'm going to stay here and I'm going to wrap up my bachelor's here, and we'll see what I can do after. They are on a green card.
They can always come back.
They always come back.
They can always. That's so cool. So cool.
Yeah.
Love to hear more about that. And then next to me.
Hi, I'm Chantal Deen, and I am from Delft, so I can just take care of your daughters.
Cool.
No
Okay.
problem.
Awesome.
I can share my address or her address.
Yes,
with
please
you.
do.
Yeah.
Please do.
Yeah.
I don't live in New York. I live in the Netherlands. I work for a private health insurance company near The Hague. And what we like to do is visit all the countries, not every country in the world, but a lot of countries where our clients or insured persons are. And that's why I'm here. I also have 2 kids. The oldest one, she studies law in Leiden. And the other one is now in Asia, doing things I don't want to know. And he always tells this, when he's done it. Trust me, it's no fun to hear that. And my husband is at home with our puppy because the kids are out of the house. So what do? You take a puppy.
Take care of the
So
last
that's me.
The last child.
Exactly.
Right? Yeah, that's it. So I think almost the three of you have had your experiences with the U.S. healthcare system. Marthe, maybe I can start with you. You came here 5 years ago, you said, if I'm correct,
Yep.
and you needed healthcare. What happened, and what was your first experience?
Well, for me, of course, my first experience were more content-based. So we came as a group of Harkness Fellows, notably to the US, to learn about the system. And I'll give you two impressions. One that was really good, and then one that's not so good. I think what's really good in the American healthcare system is that not every new idea needs to be vetted by a government to then be implemented uniformly everywhere. Here, if you're a hospital administrator or a doctor, you have a great idea, well, you just implement it in your hospital. So it's a much more agile system. So, for example, when I came as a Harkness Fellow, I did research and wanted to search for successful examples of antibiotic stewardship in the US. The Netherlands is renowned for its restrictive use of antibiotics, at least in humans. And the US is the other way, is the opposite. So my colleagues were laughing, what do you do, looking for best practices? But I found plenty of them. And for example, it's called audit feedback on individual provider behavior. So in US hospitals, they have, in some of them, they have lists, transparent lists of doctors, names of doctors, where for everyone to see which doctor, and that tell you which doctors are writing antibiotic prescriptions appropriately and which ones do not. And the goal of these lists are that the low-performing doctors can go to the high-performing doctors to improve themselves, and they can be targeted by education. And those interventions really work. So in these doctors' groups, unnecessary antibiotic prescriptions really go down. So I thought, this is a fantastic idea. We have to do that in the Netherlands as well. But I think that the Dutch doctors, and I don't know what you think, Jaap, are very keen on their privacy. And so this idea of transparency and performance really never took off in the Netherlands.
Because my personal experience in the Netherlands is they don't prescribe antibiotics that fast. Actually, they even became more strict and started to...
in the Netherlands, you mean?
In the Netherlands, yes. Is that correct?
Yes.
Is that my perception is correct?
Yeah, we are very strong in antibiotic stewardship, but in the human side. I think in the animal side, it's a different story.
Because also, I think the topic is more about super bacteria that will take over and that are antibiotics resistant, and that's what the Netherlands is afraid for.
Is trying to, of course, by not over prescribing antibiotics, you try to prevent resistance, and if resistance really becomes a problem, a lot of interventions that we do now, like a hip surgery or neonatal babies, that won't be possible because there is a lot. There will be
and your first experience with the U.S. healthcare system. So you came here. Did you have like a moment where you was like, "Wow, I didn't expect that," or "Wow"?
Yeah, so that's these kind of innovations.
Yeah.
I think the room for that is great. Mm-hmm. On the other side, so the bad.
So if I may weigh in there, I think yes, there are absolutely examples of that, but honestly, I don't recognize that in my hospital because I think it may be very localized in some of these hospitals.
Yes.
So it's not very widely implemented.
Exactly.
And there's a lot of resistance here. Antibiotic, let's say, way more than in the Netherlands. So I think, yes, I agree. I recognize these kinds of, let's say, initiatives, but it's very localized.
Yeah,
so
it's pockets of innovation.
Yeah, exactly. So what the impact is on macro level, I don't know.
Yes. No, that's totally fair. Totally fair. But there are ideas that I think are worth translating.
Yeah.
But then
and you can do these things,
Yeah. And the ugly side, of course, is the cost.
Yeah.
So the US spends 4.7 trillion on healthcare, and to make it more tangible, if you break it down to individual patients, Per person here in the US, it's $13,500 that's spent on healthcare.
Wow.
In the Netherlands, it's 7.5.
Wow.
So it's a little bit
like
more
half.
than half. Yes,
And that's a year, right?
and that's per year. That's indeed every year.
Wow.
And then a quarter of that money goes to administrative services. And that is because the system here in the US is so complicated, with large employers designing their own their own health plans with insurers, and all these different health plans have different services that they cover and different amounts of out-of-pocket money that people have to spend.
Yeah.
So
things
that's a lot of hassle.
Yeah, so things we really need to be aware of that it happens.
Yes.
If you look, Jaap-Jan, at your first experience with U.S. healthcare, you came here, you walked in, you needed medical help. Was there something or a situation where you said, "Oh, I was impressed," or was a little bit less impressed about it?
So actually, my first experience was when I arrived here in the US right before school for the 3 girls. I was not insured yet because I arrived. I was not employed yet because I was starting a couple of weeks later, and the girls needed to have a health visit. That's a thing we don't know in the Netherlands. And so I went to a private practice, or I went to let's say, primary care physician in the Upper West Side, and I had to pay out of pocket $1,500. And these kids are healthy, but you need to provide the school with a health visit document.
Wow.
If I would have been insured, I would have gotten most of it insured, but now I had to pay it out of
pocket
and,
cash.
and then he said, okay, I will not do labs, etc., because I know you have to pay out of pocket, because otherwise it would have been over $2,000.
And then you
So
would
that
have
was
known
my
that your girls have a good kidney function, which you knew really in the beginning.
I know, it's yeah. So that was my first experience.
Wow.
But I can also, because that's another thing I just remembered. Once one of the kids got an biotic, prescribed as a healthcare, provider. I can do it myself, but I said, okay, let's go to the, primary care provider. He prescribed an antibiotics, and then it was $2,100 copay.
And copay means
You have to pay it.
out of copay.
Out of
But
pocket.
it's
Yeah.
likely not copay, no? It's likely a deductible.
No, it
so you
was
have to
copay.
get
It was
to your.
copay. But $2,100.
A
That
lot
seems
of
a
money.
lot.
A lot of money.
So I didn't take it.
No.
So I said, I will fix it another way.
Chantal, if you listen to the examples here,
Yeah.
you probably can see from your side and recognize those situations, or not?
Yes, I do, and I think that for us, the U.S. healthcare is like complicated. It's not like anything in the Netherlands, and I dealt with it once in 2016. I had a terrible headache, and I went to like this medical pop-up kind of thing, and I saw 5, I thought, doctors with white coats. And then the 6th came and told me, you have a migraine and you need to get, your pills. And when you come home, you have to go to the neurologist. And I was like, what? And they gave me a coupon. So that was very interesting. And I went to the Walmart and went to get my drugs. And they were like, how many do you want? And I was like, what? They would never ask you this in the Netherlands. You would just get, 10 to 15 pills. And I was like, it's not antibiotics, is it? No. I was sort of,
give me 100.
Just give me 25. And then...
Give me 100 of those.
I think the first price was $90. And then I gave the coupon, and it was $19.95. And my husband, he studied chemistry, and he was like, just show me, please. Let me
What's
know
on it, yeah.
if what's in there, because you're not going to take it if there's like, And so I was good to go, and I took it, and I must say, the migraine just disappeared. But when I came home in the Netherlands to see my general practitioner, he was like, what? on earth that they give you. They will not give this to you, not even by a neurologist. So I think that I hopefully sums up the difference, for us is that you can get all sorts of types of medicine or drugs, how do you want to call it, that we won't get in the Netherlands, as we don't get antibiotics that quickly.
Interesting, because my next question would be also like, if you have people moving or visiting the US, what do you think they struggle the most with when they need to go to the US for visiting or vacation or working here? Especially from your background, like what do you see in general where people struggle the most with?
Well, that's interesting because I just spoke to a Dutch guy, and I think the most common mistake is that people think that they can travel with their national health insurance of the Netherlands to another country, but that's only for emergencies, and then they will pay you what it will cost in the Netherlands. And as we know, the prices here are completely different from the ones in the Netherlands. Even on the travel insurance, they will just ask you, what are you going to do? Are you going to work here? Are you going to live here? So I think it's very important to do your research before you leave.
Marthe, do you also recognize that from your perspective?
No, I think there's two things. So it depends, of course, if you live here and you have something where you come over. For people who live here, but maybe also visitors, it's just very hard to know where you go with a complaint. So what's the point of entry in the healthcare system? In the Netherlands, you go to a huisarts. And your huisarts, he treats you, and if it's too complicated, he passes you on. You can go there day and night. Here in the US, a third of people do not even have a primary care physician. Mm-hmm. And they certainly can't go there at night because they're closed. So then the question is, what happens if you get something? And maybe I can give the example. When we just got here, my daughter got a cut in her knee because she played tennis at night, and it needed stitches or glue. So the primary care was closed. Urgent care center, that's sort of a trimmed down emergency department, was closed. So we ended up in the closest emergency department, which cost us $700. So what I should have done, but how do you know, is search for the next urgent care that is open. But if you're in a rural setting, that may not be there. Mm-hmm. Or I should just go to the CVS and buy the glue myself. Yeah. And so often I refer to just postponing care and just not going to see a doctor because I'm afraid of the financial ramifications, which of course is not a good idea either. No. And I think my disappointment with the system is that the system is not educating patients and helping them navigate, because this nurse in that ED that we ended up in should have said, oh, wait, don't come here, it's way too expensive, go somewhere else. Yeah. But of course the nurse has no incentive to tell us to go elsewhere. Yeah. So as a patient,
that's what you see
do you
a lot.
Recognize that?
That's what you see a lot. That's what I see a lot as well, because a lot of people need to pay out of pockets huge amounts of their money. So they really postpone care before they come to the hospital. And actually then it can be even worse. So in the end they may be even worse off because they have a bigger complication. Yeah. And they really postpone because they know if they go they have to pay.
Yeah. Is it true, as some people would say to me, like the Dutch healthcare system is all about prevention? And here in the US, it's all about fixing. Is that correct or no?
I don't think so.
No,
I don't
it's not
think
correct.
so.
No? Why don't you think it's correct? What do you?
I don't think so, because if it were about prevention, then they should educate us as well. And I don't experience that at all. I think prevention is not the right word. I think what happens is that if you phone a Dutch GP in the Netherlands, say on Monday morning, and you're like, oh, I just feel sick and I have a fever and, can I make an appointment? Then he will say, if you're still feeling bad on Friday, you can come. So, but that's got nothing to do with prevention, but more learn to deal with it and don't come for everything. Because, I think that's it.
And if you then look at the comparison between the U.S. healthcare system and compared to the Dutch system, Marthe, how do you look at the comparison? How would you pinpoint that? And then I will come to you as well, Jaap.
I think there's three things that are important in the comparison. One is the way insurance is set up in the US compared to the Netherlands. One is, I think, the place of the primary care physician. And the third one is maybe the enduring chaos that people have to live with here in the US. To start with the insurance system, in the US, the insurance is employer-based. So that means that if you're under 65, you pay together with your employer your health insurance. If you're over 65 or fall in specific buckets, like you have very low income, or you're disabled, or you have end-stage renal disease, or are pregnant, then your insurance is paid by government. Over 65 is Medicare, that's CMS regulated. And then in the other buckets, you're eligible for Medicaid, which is more state-based programs. And this employer system really has its roots in the Second World War, where inflation was very high. Employers were barred from raising wages to tame inflation, but they were allowed to compete for scarce employees to offer benefits like healthcare. And then their contributions were tax exempt, and then no one wanted to touch that system anymore. And of course in the Netherlands we have more of a managed competition. We have gereguleerde marktwerking, and where also we have, you pay your premium, and then employers and the government pay into an insurer fund that then pays the insurer. So we also have a mix of government, employers, and commercial health insurers. We're not, and that's many people here in the US, when they speak to me, they say, oh yeah, the Netherlands, it's a single payer. But it's not true.
No, it's not.
And we're not the NHS,
No.
where indeed in England.
And Chantal, you recognize that as well, right?
Yes, I do. I think that what you, it's nice what you mentioned, because a lot of people in the Netherlands, they're like, we're paying for the other person, we're paying a lot of money, and I'm like, you should know the premiums in the US, because I've heard people paying $600 a month.
Yes.
Wow.
And
that's
then
right.
having a deductible of $13,000. And
Yeah.
in the Netherlands, it's $385, and you can
Yeah.
even, up it if you want to.
Yeah.
I
And
don't.
copay here.
And co-payment, and
If I compare mine, it's like 6 times more than what I would pay in the Netherlands.
yeah.
And here it's a true problem. I think that 40% of individual bankruptcies comes through
horrible.
medical bills.
Yeah, the number one bankruptcy in the U.S. is healthcare system. So people that either get homeless on the street is most of the time because they got
Can't
a
pay their
sickness.
medical
yeah,
bills,
they
yeah.
can. Yeah, so it's really it's a big thing.
Yeah.
It's a big thing. So better be prepared. Then, Jaap, maybe you can tell me what's better and worse when it comes to health insurance in the U.S. and the Netherlands. Do you have a kind of a feeling if I make the comparison, I like, for example, in the Netherlands that we have this and this, but I also like this and this about the U.S. system.
So honestly, I like it to work here because I can do my things. I can bring my research to, let's say clinic. So
Yes.
that's cool. So I can do these things.
And you also have your own
I
laboratorium,
have
right?
my own lab.
Yeah.
And I have my own servers, and so if it really comes to advanced things,
Mm-hmm.
if you have end-stage cancer, and in, let's say, Europe, they would say this is palliative care. We don't have anything anymore. But here there is still an option. You can get enrolled in a clinical trial, and and also FDA-approved products, CAR T cells, are available much faster here than in Europe.
Mm-hmm.
So in Europe it's lacking a couple years behind.
Yeah.
But that's only for that very specific group of patients.
Yeah.
Generally speaking, I think the healthcare in Europe is much better in the Netherlands
Okay.
because you have access to everything. And you will not, let's say, bankrupt,
No.
because it's max 360. What is it?
385. Yeah.
But that's nothing, because here, for you, what was it? It really depends on the plan. So for us, it's 5,000. And then there is a copay max, I don't know, 5,000-6,000. So it's
With 10.
way different numbers. But if something happens on January 1st, they may, let's say, present you a bill of 5,000 and you have to pay it right away, or in the, let's say, following week. So you need to save money for these incidents, for these
Unexpected
things.
incidents,
Yeah.
financial impacts based on the healthcare system.
Because on the, yeah, so, but you can save money pre-tax here. So, in summary, I think for certain specific, let's say, groups, you can have access to more advanced therapies here. And I use, let's say, cancer as an example, but the same is true for other things in heart disease, etc. But generally speaking, when you have a standard issue, maybe a little bit more, let's say, complicated, I think the care in Europe and the Netherlands is better because it's accessible for all. Because here the advanced therapies is not accessible for all. So we
You
are in
can
a
see
very,
that.
let's say, privileged position because we would have access.
Yeah.
But I think 80% or maybe even more will not have access.
You
So-
can see
so-
it in the outcomes of care here in the US. Where
That's
if
a
you
good point.
if you think of a life expectancy for a US man that's 75 years, then in the Netherlands it's 80.
Wow.
But then if you look at the different socioeconomic layers, the top 1%, the richest American men, they live up until 87. So that's 7 years more than the average Dutchman.
Yeah, so,
And
so
that means that the poor Americans really live
They
a
are
lot,
low,
lot
yeah.
shorter.
That's because the care for them is available.
yeah, they have access. And so what I feel and what I'm sensing here is that I really need to make sure I'm covered before I go to the US instead of looking for my insurance afterwards, right? Do you guys can share some stories, and maybe it's good for you to start? Like, do you see the stories that you see that people go into the US, just go here for vacation like we do in Europe? We just go, we book the flight, we never looked into something, and then what happens? Can you share us some examples of what happened?
Well, this was last year, I think, in the news in the Netherlands. It wasn't exactly the US, but it was Mexico. And as we know, the prices are similar to the US because there are a lot of private clinics. There was a Dutch yoga teacher, and she went in to do a detox. She forgot to take out the travel insurance. The detox went wrong. She went into a coma and was in a private clinic. And her friends, they were, crowdfunding and very mad at the Dutch insurance company. But they were like, we can do the emergency, but just only what the price will be in the Netherlands. And at the end, the crowdfunding didn't, close the gap. So I don't know how they did it. But this is a good example, I think, of people that forget to take out a travel insurance because nothing will happen to me.
That's one. And the second thing is, I'm insured. I have my basic health care. I have my travel insurance, so that all...
Well, she didn't.
She didn't. Oh, she didn't even have a travel insurance.
But I think the thing is that what surprises me the most, but that's because we're in the business, is that people are really angry. They're just mad at the insurance company. I'm like, but you have a responsibility, to think before you leave a country or go to another country to see what is healthcare like there. Yeah. Because people, we know that from our clients, they don't want to be in a hospital, and it doesn't happen here in the US, but in other countries where the chicken and the goats are just walking around the hospital, it happens.
Jaap Jan, do you have an experience in this aspect where you go like, oh boy?
So it also depends a little bit on the state where you are.
Interesting.
Yeah.
Not
So-
only the country, but the state is different.
And I can tell you the story here from New York, because in New York, the state law, if you are a pediatric patient and something happens, you will get emergency Medicaid. So you will be insured. So, but that's not true in all the other states. So if you are here with your kids and something happens, and even if you miss all these additional insurances because you're here. New York State will pay for it. So there is an emergency, but only for pediatric patients.
Exactly. And
But in general, in New York State, it's almost like a second economy where if you're not insured, there's a lot of places that are specifically paid to take care of the uninsured, like undocumented immigrants.
Is it like the hospitals that just...
So it's in a hospital. You will get emergency medicated
there are some
in
hospitals, right, here in New York, where you can just get treatment without insurance?
Well, of course you get treatment.
Yeah.
But if you're uninsured, often... So once I was in between jobs and indeed needed x-rays for my daughter's arm, and they were surprisingly cheap. And I even called them, and they said, well, that's because you didn't have insurance.
Yeah.
And there are even people in the US who say, you know what, I forgo insurance, then I don't have to deal with these high deductibles, and I'll pay the lower prices out of pocket, which is a gaming of the system. It's horrible, of course.
Quite risky.
Yeah, and risky as well. And then, we're talking about coverage, but what about vaccinations? Because, everybody is like done with COVID and stuff, but vaccinations is still a hot topic, I think. I think it's very important. But can you tell me, Marthe, what happens when, you come into the U.S. healthcare system? Do they pay attention if you
yes, in the lot.
They do?
And I have to say, the best tip I've ever got before moving to the US was make sure that your primary care physician writes you a little note that says that your child has had chickenpox and the date of the chickenpox. Because every school your child goes to will say, hey, he wasn't vaccinated for varicella. Can you prove that he has chickenpox? And if you can't, you'll have to vaccinate again. Because of course here in the US...
Or titers.
Here in the US they vaccinate against chickenpox, and we in the Netherlands say, well, you can get the disease, and that's the same, then you have the same...
that's a natural vaccine.
It's a natural vaccine, exactly. So that, and the other thing to know is that the windows here in the US vaccination schedule are very tight. So you have to have had your TDAP, which is the DKTP, in a certain window after your 4th birthday, or your 2nd birthday. And if you're 3 days late, tough
the
for
school
you.
is chasing you. Yeah.
You have to revaccinate your child. And trust me, I tried to debate that with a lot of layers, but no use. So you just have to go with the flow.
No, and some of the vaccines they don't accept because it's not an FDA-approved vaccine, but only an EMA vaccine. So please be...
EMA meaning Europe, right?
It's only in Europe. So we had to repeat a couple of vaccines because they were not FDA approved, but they were only in Europe approved.
Which is
so
not
be
the end
prepared
of the world
for that.
either.
Yeah.
And what type of vaccines were they? Do you know that?
I think this was meningitis.
All
so
right.
we needed to redo that here.
It's interesting.
Yeah.
So on the one end, you get vaccinated in Europe. You need to bring your stuff, but then even if you have your vaccination, you might have not have the ones that are required here.
And don't worry about it too much.
No. But it's good to know because we're covering so far all of the different angles. Like you go there, you're not insured, you didn't do your research. What happens? Then now, hopefully, you're informed by these brilliant minds here, and they're like, okay, I'm coming in more prepared. But then, what can I do, like, really to, protect myself from a financial loss? Because that's what it bottom line is. Next to the fact that have a health loss, hopefully that gets fixed. But financial, it's impacting as well. And I think everything is ×3. I learned in the last podcast. So all the prices here are ×3. So it's a good that X3 is like in the back of my head, like take it serious, right? That's the thing. I heard something about being in network. I see you nodding. Please tell me, what is that, in network?
In network is it depends on the network provider that you work with. We work with United Healthcare, so people can go to any care place that they want as long as that has United Healthcare. And so that would be in network. And I think mostly around New York, Florida, and California, where our clients are based, that is okay. But you could fall out of network, and then you would have to pay maybe 25% yourself. It happens in the Netherlands as well. It's starting to become more common that healthcare insurers make like deals with hospitals. So you're my hospital, so I want every client to go there. And I think here in the US, people are used to it. As we know, since the murder on the CEO of United Healthcare, there's been a lot of discussion about that. So I think that works because for us, it helps us with the cost containment. Because we need to keep the prices, the premiums low.
Yeah,
and they can do that.
Yeah, of course. And but the thing is, like, that's when you know healthcare is coming. But when you're like in need of urgent help or urgent matter, and you're already like, I'm feeling sick. I need transportation. They're bringing me somewhere. Like, how can you influence that? Because then it gets
difficult. It just is because how often is one conscious? You don't know.
No.
And no, it's difficult.
So basically, it's a good thing to think this through.
Yes, and we tried to make we tried to divide it: emergency and planned care. So there's a difference that that you have a new hip, or you need a knee surgery. Yeah. So that can be planned, and then you can be. We can move you to a hospital which is in network. And if it's not, I mean, it has happened. You want to know an example?
I also maybe have an example, but tell me. Yes, please.
Okay. In 2021, we had a Dutch lady. She was pregnant, 27 weeks. And she was going into labor, and she still lives in West Hollywood. So that's close to Beverly Hills. And she was rushed to a hospital. So she wasn't really, thinking very clearly. And she was brought to the Cedars-Sinai. That is one of the most expensive hospitals, if I'm right, in the U.S., as is Mount Sinai in New York. And she gave birth to a very healthy toddler right now. And the baby had to stay in the hospital for 16 weeks. And we got the original invoice. So that's the difference. We have the original and then comes in
the negotiated one.
Exactly. So the original invoice was $3.7 million. And we were just gobsmacked in the Netherlands.
$3.7 million for giving birth to a premature baby.
But what you can see here, which is something that we could learn in the Netherlands, we can read everything on the invoice. And so we saw that 83% of the cost was just the location. Location. So the medical procedures weren't that high, but it was just her staying in the
bed. Yeah.
Exactly.
Wow.
It felt like the House of Cards. It's like location.
Yeah, because that's the thing. Like you're talking about location. I have a little sidestep. In the Netherlands we celebrate King's Day, and back in the day, in my time, it was Queen's Day, and I was walking there with my best friend, and we were walking there, and he was like walking with his hands in his pockets, and we were walking to one of the squares, and then all of a sudden he tripped. So he tripped, but then because he had his hands in his pockets, he fell, and his teeth were on the street. So it was awful, right? It's an awful situation. Like hands in your pockets, you got like this. So what did I do? I pick up the phone. I started dialing the dentist. The dentist said, well, in this case, you need to go to ER. So there we went in a taxi to ER. I think if you are in the US, is that a good idea to do, to visit the ER first thing?
No?
Tell me why.
Because it's expensive, but it's also difficult because the general practitioner that we have in the Netherlands is not very common around here. So, and not everybody knows. I wouldn't even know where is the next, nearby medical clinic that I can go to. So to navigate, I think that you can tell us more.
Marcus, ER, going to the ER with a headache, is that a good idea?
Remember when you asked me what are the characteristics of the US health system, and I said the third one is chaos. And so this is the chaos. One is you don't know as a patient whether or not your pain in your chest is a heart attack, for which you have to go to a cardiology hospital or a hospital with or if it's a muscle problem, you could just as well go to a PCP. As a person you don't know
wait
yet.
another day. Yeah.
And so that feels it's anxious generating. So that's one. And then the second one is, like you said, you have, for the same intervention, you get bills from the provider and you get bills from the hospital. And the provider practice and the hospital both have different financial departments if you have questions that you have to talk to. But these departments often do not talk together.
Nope.
So that's the second part you have to navigate. Then there's the in and out of network that you said. Yes, as a patient, you are indeed responsible here to know if the care you're going to get is in and out of network. What do? You call your insurance. In fact, here in the US...
So basically, you what you do when something is wrong, you first call your insurance and then you seek for help.
You never, ever do anything without calling them, saying, A, is my provider in network? If they say yes, that's not enough. Then you ask, is the location in network? Is the hospital in network? It's the second question. Then what they can do too is, what you should do as a patient is compare different providers, and they can get you different quotes if you have the DRG code, if you know what's going to happen. Often, if your kid has an operation, but they can't give you a code because they don't know yet what they're going to find, then it's impossible to know in advance what it's going to cost.
But when there is a real emergency, you need to go, of course. But you need to weigh a little bit. Is this a real emergency or is this a thing that can wait?
Yeah.
Because it's a real emergency, you need to go.
Of course.
Yeah.
I heard that from a client of ours in New York, that she was like, I need to go, but I'm not going to take an ambulance, so I'm just going to, call an Uber.
Take the Uber, yeah.
That would be unthinkable in the Netherlands.
I would be very careful here calling an ambulance on someone.
Yeah.
He's the first one to know if he's good and well insured.
Yeah, I think an ambulance is like $1,000 to $2,000 already, right? Just for it's a very expensive Uber, basically.
Yes,
yes.
You can get a great Uber for that price. Yeah.
Yeah.
So then, if you look at bills, and in general, you have a bill, you are after the fact, like you were in need of help. You come to the medical provider. Is there something I can do which is related to the bill? Does anybody have some tips or advice on that? You have, yeah?
Yes, I have a tip. Don't
pay.
Don't pay.
No.
Do not get
Never?
lured with a discount, because we can get more discount than you. What they will do, we've
As an
experienced
insurance
that.
provider
Yes.
from the Netherlands, you get more discount.
They will say, if you pay now within 14 days, you will get a discount of 20%. And you will be like, this is great for my insurance
I'm
company.
Dutch.
I did good.
I'm Dutch.
I'm
Yeah,
Dutch.
right. Yeah.
Don't do it.
Yeah.
Let us negotiate.
Okay. So what if they say, if you don't pay, we don't treat?
Well, what we do, we work with an emergency center that you can call 24/7.
Okay.
And they can give out the guarantee of payment, because that is the only thing
They
that
wanna
they
know,
want.
yeah.
They want to know, are you paying for it?
Yeah.
Yeah.
So it's always like the first thing you do. So basically, if I'm like traveling to the US, I've never been there. First thing I do is like, okay, I have my basic insurance. It's not enough. I add my travel insurance, which should be, let's say, sufficient.
Exactly, for a very short period.
For a
of time.
very short period of time. But if my stay is a little bit longer, I need to just add insurance,
Exactly.
especially for this country. And then I also need to put the phone lines of my insurance, of my basic medical care in the Netherlands, de zorgverzekering, in my phone. And if something happens, I consult them first before I make a move. Is that
No,
no?
it's not correct.
It's not
No,
correct.
I'm sorry.
Okay.
Sorry,
Please.
Mark.
So we're sometimes
See?
talking about
I'm
different settings, right?
exactly,
You
because-
often talk about people who come to the
Yeah.
US, and we talk about people who are
In
here
the
and
US.
Yeah,
often
yeah,
have
true.
employers.
That's
If
true.
you
Yeah.
keep if you're here on like a holiday or just for a short period of time, I think there should be a difference, because your health insurance is not, the Dutch health insurance is not for care that you can plan. It's emergency. And if you will stay longer than, say, about 8 months, it varies from insurance company to insurance company, they will just ask you questions. Mark, what are you doing in the US? Are you living there? Because if so, that's not what our insurance is for. So if you leave the Netherlands, are you gonna, enroll yourself here in I don't know what it's called, but yet that you will move into a house, that you will rent a house, then you will schrijf jezelf uit in the Netherlands.
You will basically leave the Netherlands.
You will leave the Netherlands.
You
will still
register
have,
here.
Exactly.
You
will still
unregister in the Netherlands.
Be a Dutch citizen, but you will register here, and that will mean that the Dutch health care, you no longer have the right to take that out. So think about that before you leave.
Yeah, definitely. Yeah, and the thing is, like, you guys made me think of a lot of things at the same time. So I think we should definitely just do a second podcast on this matter because we have more to talk about, right? So thank you guys so much for this part. It's very valuable information. I learned so much. And really looking forward to the next episode. So let's do that.
All right.
Thanks.
Thank you.
That's good. Thanks.